Welcome to the HealthCast, where we explore the intersection of healthcare, technology, and business innovation. I'm Phil Zappone, family nurse practitioner and founder of NXAI Growth Consultancy. We help healthcare companies grow with AI and automation. On this show, I speak with founders, clinicians, and innovators who are building the future of healthcare. Welcome to another episode of the HealthCast. Super excited to have Dr. Natasha Dole on today, ER physician, consultant, and digital health leader. Welcome, Natasha.
Thank you so much, Phil. Delighted to be here.
Pleasure to have you. Let's just dive right into it. What initially drew you to medicine and specifically emergency medicine?
So I'm going to answer the latter part first, if that's okay. So emergency medicine for me is the best 10 minutes of every specialty. So I love fixing things. I love puzzles. I love unpacking things. I love dissecting. And most importantly, as weird as this sounds, I love blood and I love being able to stop blood. So my only two options were emergency medicine or surgery. I tried a bit of time in surgery and I realized it wasn't the right fit for me, whereas emergency medicine was giving me the fix that I needed. And I love the adrenaline rush. I love the trauma and I thrive on it. So yeah, like I said, it's the best 10 minutes of every specialty and I get to fix people, which is what I love.
Yeah, well, I like that answer. Were there academic mentors, experiences, or pivotal moments that shaped your path?
I don't think so much in terms of my upbringing, because I'm the only doctor in my family and I'm the only one that doesn't actually find blood or vomit queasy. So I don't actually know where it stems from, but I do remember one poignant event whilst growing up in my childhood. My younger brother, who's quite a lot younger than me, injured his wrist quite badly and was very lucky in just missing the right things and needed sutures in the ER. I took him there and, I was all sort of heroic and this is way before we had proper regulation thinking, I could do it. And it was the first time seeing him as a patient, a loved one, needing sutures and understanding how lucky he was that he'd, not injured it severely enough and had severe hemorrhage. But I just couldn't, I couldn't even hold his hand. And that's when I got queasy. And that's when I was like, I can't handle the blood. And it was just, I think for me in that moment in time, I realized that you absolutely cannot be around a loved one or someone you care about, despite knowing what to do. And similarly, when one of your loved ones or family or friends are injured, and then you want to hear it in medical lingo, but suddenly your brain just can't process it and you become a normal human that needs normal TLC rather than attending or a physician that knows these big fancy medical words. As I've grown up, there have been some absolutely academic, inspirational mentors along the way, and those I sort of strive to emulate on a regular basis. And it's not so much as somebody famous, but just people along my path that have helped me shape me into who I am. And I almost want to say there are too many to name, but they're all sort of internationally spread, and they've each added a part of themselves into me, and I think that's what's made me me.
Was there a specific defining moment when you realized you wanted to explore things beyond the bedside in terms of digital health and your technology background that links with medicine?
Not quite a specific moment, but I do remember thinking I needed to get onto the ultrasound wagon because at one point the ultrasound was being replaced by, sorry, the stethoscope was being replaced by the ultrasound. Yeah. And I realized I was behind in that area. And then when COVID hit, I was obviously practicing medicine in unprecedented times. We were seeing things and doing things we'd never done before. And there was a research opportunity, Oxford University, where I was training, to get involved with a AI tool that was a point of care AI tool to test COVID. This was way before lateral flows had come in. This was the first wave. People were unvaccinated. We were absolutely swamped and bombarded. We were basically just trying to separate clean versus contaminated areas in the ER. And I got asked if I would like to help in assisting with that project and the benefits that came out of that project. So basically this AI tool was a point of care test at the front door with the finger prick and a specific type of blood sample taken along with a set of vitals, including your saturation levels, which was then put into a device called the OLO device, which was an AI device based on an AI algorithm that was giving us an answer about whether or not this patient had COVID in 16 minutes with a 99% accuracy. And it was 26% more accurate than the lab results we were getting. At that point, PCRs were the only thing we were doing. This was way before lateral flows. PCRs were taking 6 hours. So for 6 hours, we were in that unknown zone of, is this COVID? Although clinically it most likely is. But we didn't have a definitive answer. And then the specificity and the sensitivity of that was in the really high 90s. And it also had a really good negative predictive value. So that was my first insight into AI. And I think that opened up my world into wanting to explore it more in the pandemic. And I think that's where I got my foot in the door. And ever since I've fallen in love. with AI. And then I think I've spent basically all my CPD and SBA time. SBA here is supporting professional academic
Nice.
academia. I've just sort of kind of driven into my passion, which has become digital and AI, because it's just changed the way we're practicing medicine. It's enhanced me in terms of my professionalism. It's given me my time back. It allows me to have more meaningful connection. And most importantly, it's made me more productive and more efficient. Especially the more senior you get, the cognitive burden is a lot to carry and decision fatigue. So it has really, really helped with that. So I think because I've seen the professional benefits, I've translated that into my personal life, and then together combined, it's just been a great win.
Yeah. I think you touched upon it. I'll just read it anyway, just in case there's anything else to add. How did you link clinical training and the innovation world?
As a trainee, we were given X amount of time that was for training and development, and you could use it whichever way you wanted. So initially, in the earlier years, it was to pass all your exams, sit your exams, your vivas, your OSCEs. So once that's out the window, you've obviously still got more years of training. And then you could do what you wanted. You had a study budget every year whilst in training. And I must admit, I spent way more than my study budget. But I started realizing there was lots of opportunities actually for free online. There were many courses coming up. So I just started exploring different AI tools, and I started networking. And then I started getting involved with piloting different AI tools within different NHS trusts that I worked with. One thing led to another, and then networking and meeting like-minded people just helped me build and grow. And then I think that's when I started seeing the harms, the inaccuracies, the biases. And that's when I decided, although I'm an AI enthusiast, I'm very much aware that there needs to be a human in the loop 24/7, 365 days. That's where my stance comes from.
What problem are you most passionate about solving right now?
I wish I could solve overcrowding and exit block currently in the emergency department. That is a big, big problem in the UK. And the other big problem is getting GP appointments. They are absolutely swamped. Patients end up in the A&E because there's nowhere else for them to go. And they don't necessarily need to be in the A&E, and I don't mean that with any disrespect, but this is something easily a GP could have sorted, but they just can't get GP appointments. I think what worries me in patients being aware that they can't get GP appointments and then they default to the A&E because in that interim, they default to an AI output and they put in their data, which is very inadequate and insufficient, and it goes blank into the World Wide Web, and then the output is equals go and see A&E. And then they end up in A&E. And I've said this before, what worries me more are the people that don't show up to A&E, because the ones that come in, I can actually use that as an educational moment to tell them, you did need to come in, this is your problem. Or the opposite is you didn't need to come in and these are your alternative options. Whereas the ones that don't come in and are completely reliant on the AI tool, especially when I hear I've got the paid version of this AI and they trust it more than they trust a human doctor, is where things start to get very tricky.
That human behavior element that you're describing is the same, it sounds, in the UK that we experience in the US.
Yeah, absolutely.
I completely understand.
Governance and human in the loop are things that are just, and I think we're so behind and the tech is way ahead of us.
Yeah.
And we're not ready for that. The mindset adoption is not happening. The readiness within the organization is not necessarily happening. And people are not AI and digital literate. And I often hear people saying, I'm not tech savvy enough for AI and I don't have time for AI. And in fact, those are the two population groups that need AI the most because it will help them the most. So it's change, isn't it? Everybody hates change, and it's trying to get them on board to understand why they should be using it and how they should be using it wisely and responsibly.
What's driving you personally in this phase of your career?
So I think the fact that I'm able to follow my passion in and out of work and whilst at work. So I am absolutely an AI enthusiast. And like I said, I love trauma and I love A&E. And currently being digital lead whilst being clinical gives me the opportunity to blend what I love with my passion, which is also being clinical and seeing patients on a regular basis, and then experimenting with them, but in a space where I have a really supportive work environment. I have a very, very collaborative workforce, and I get to, like I said, network regularly with multidisciplinary teams. And I think had it not been for me being digital lead, I would never have known about the top-down, bottom-up approach. I would have never met important people in the hospital I work with, or even outside, like executives, other organizations. And I think LinkedIn has been a huge platform of growth, which was completely, completely unexpected. And I mean, LinkedIn, everybody keeps asking me what my brand is and what I'm trying to sell. I'm not trying to sell anything. I don't have a brand. I have no intention of learning how to code. I'm very happy with what I do. But my main voice on LinkedIn is to share the wise use and the responsible use of AI, especially in the clinical world and especially in emergency medicine, because we are miles behind. Cardiology, oncology, radiology are miles ahead of us, and we really need to catch up.
Yeah. On the show, we sometimes talk about burnout. I'm hearing your passion and your enthusiasm for what you do. So that's awesome. I love it.
Thank you. I want to actually interrupt and say I have been burnt out, and I think that's why I feel so passionately about it. And I think once you become a patient or once you go through something that you often treat in the emergency department, one is it's 100% true that doctors make the worst patients. And two, it really takes a lot to ask for help, even though you know deep inside you need help. And it's,
Yeah.
I was saying to a colleague recently, it's about giving yourself the permission to take the help. The help is available. You know what signposting there is. You need a day off. And sometimes you even know that a day off isn't just what you need. And I think I've also realized since being a patient and also having had COVID and being burnt out, it's so much easier to spot these things in other people. And I think it's made me a better human and a better doctor. And I'd like to think a better supervisor and a mentee or a mentor to recognize it in junior colleagues and even in senior colleagues. I mean, there's a shift, and because you've been through it, you can see, and
Yeah.
it's the little things. And I remember when I was burnt out, I remember somebody I really deeply respected, and I still do, a really close friend and colleague, saying to me that he was worried about me. And I said, "What exactly is it? Do you think I'm making mistakes? Have I had a complaint? You know, what have I done?" And he just said, "Your eyes don't meet your smile." And I remember thinking, wow, that was the last thing I expected him to say.
Uh,
And he's like, "You are someone that just loves caffeine, loves adrenaline." And he's like, "I can't think of the last time I saw you have, last time I've seen you have a cup of coffee, and that's something you genuinely love." And then he said, "Have you gone off coffee?" And I thought, "No, I haven't. I just don't feel like it," which is really, really unusual for me. I mean, I'm a total caffeine addict.
yeah.
But it's amazing how just little changes like that, could be something more telling of a deeper something else that's going on that needs unpacking.
Yeah.
Um,
I have this expression I made up. I used to work some outdoor jobs with raft guiding and ski patrol and whatnot, and just outdoor recreation in general, some of the risks that it brings with us. And I think I had made up this term that I called "not me syndrome." And I think it can apply to lots of areas of life where people think, oh, but those situations, like when I'm talking about, say, especially with men in primary care, talking about, say, colonoscopies, and I feel like they have this, well, that only happens to other people, not me. I think you're saying that with experience, we all learn some humility, which can be a
Absolutely,
growth
right?
opportunity.
And then I think I've also learned that kindness comes in different ways and shapes and forms, and a little tiny something can mean so much more than a really, really big gesture. And I've also realized that often we say, "How are you? Are you okay?" But nobody really waits for the answer. You just crack on and move on. And no one is actually going to say to you, especially if you don't know them and you don't have a close relationship to them, that they're struggling. And it could be in really simple things. A couple of months ago, we had one of our trainees who was just perpetually late. We had spoken to her, we had unpacked it, she had commute. There were so many things going on that she just didn't feel comfortable telling us and sharing with us because she thought it would be used against her. And I think in 2026, we are finally in a space where we can break that stigma about mental health. And people
Yeah.
can see they're struggling because the other thing linked with burnout is compassion fatigue. It's difficult to switch off, especially in a high-paced environment like A&E, and especially as a woman, especially if you want to take maternity leave or you then need to return and then you have separation anxiety from your children. And again, there's still that fear of, oh, what are people going to say? Training is already so long and now I'm off. And it's just like I said, the more we speak about it, the more we break the stigma to be okay with not being okay. And I'll admit it, there are still days I'm not okay, and it doesn't mean I'm burnt out and I need time off, but it's been a rough day. And I think the same mentor I mentioned earlier said to me, the day you don't get upset that a patient has died, or a day that you don't feel that your heart's a bit broken because you had a really traumatic case, that's the day you hang your hat up and then you think, is it time for me to say goodbye? So it's completely normal to feel abnormal at times, and I think it's
Yeah.
completely natural. And I think we need to empower more people to say that out loud.
I love that. We talk about mental health also on the show regularly. And I talk about some of my experiences just over time, and that's one of the things where I was going with it, is that it's one of our conversations in mental health and the growth that I've seen in my career is one of the things I'm most proud about of healthcare. As much as we all have concerns about where we're going and maybe lack of access on different points, I feel like now have an openness. We've normalized conversations about mental health. I think that's done so many people, just provided so much good.
Absolutely. And I also think the other stigma around that you absolutely need medication or therapy and that it's for life and it's going to be, a big red dot on your CV. It's
Yeah.
not. In fact, like I said, it's made me a better doctor. It's made me a better human. And I'd like to think it's made me a better supervisor.
Yeah, fantastic. Where do you see the greatest opportunity for innovation?
So I think from an A&E perspective, I think documentation at the moment is really, really the big problem that we're seeing. Pre-AI, I used to spend close to an hour to 2 hours documenting.
Mm.
Trialing different AI scribes has been a huge positive change and has really reduced my workload. And it's given me back my situational awareness. It's reduced decision fatigue. It's reduced my cognitive load, reduced my cognitive burden. But it's also made me realize the impact and the effect of the human touch, which is completely irreplaceable. And I think with an AI scribe, I can now look at the patient in the eye, whereas previously I was glued to my computer trying to frantically type everything they were saying because we've got digital health records. With AI in the background, I can have a meaningful connection. I can hold their hand and I listen to them more. And I think that's where human in the loop comes in because no AI is ever going to be able to do that. And even if we get there in 5 years or 10 years or 5 months, I'm not going to be one of those people in the, following that trend. I'm going to do what works for me. I think you need to realize why you became a doctor, why you decided to do the specialty that you've chosen to do, and how it can best support you to enhance you and to be an adjunct. And for me, at 3 a.m., it's my second brain because I'm tired. I have been running on caffeine and I'm not over reliant on it. And there are definitely times it has been wrong, but there are times it has been right and it's caught me out. But it's not, and I have no qualm saying that because I'm using it as a thinking partner and it's not my autopilot, it's my co-pilot. But I definitely am really enjoying the fact that there are certain tools that are making my life easier. And it gets me that time to switch off when I come home from work. Because I used to come home from work a couple of years ago and think, goodness, did I write notes on that patient? Did I write this referral properly? Did I do that? I don't need to worry about that now because it's done in real time, which is also great for the patient because then all I need to do is hit it to the app and then they have access to it,
Yeah.
provided it works. It's not always working, but I mean, that comes with tech.
Yeah. I want to highlight one thing that I think is important just to emphasize, even though we're talking about your qualifications and your training as an advanced emergency room physician, and your skills as an AI leader, you said holding the patient's hand. And I just think that's one of the things just to remember, and speaks a lot about you. And I think that's important for all of us to hear. I want to make sure we caught that.
Thank you, Phil. It means a lot. And I think I've realized that, like I said, from having been burnt out, having been a patient myself, I was really unwell during COVID. And it changes your perspective. It changes
Yeah.
how you practice medicine. I recently injured my shoulder as well. And I think I have a different perspective now when I treat shoulder injuries. And I think once you go through something on the other side, or a loved one goes through something, you have a very different perspective of it. I'm embarrassed to say I think I have way more compassion and empathy now than I ever did. And there's a big difference between sympathy and empathy. And I think every day is a learning day where I'm learning to differentiate between it. And then there's also the aspect of stepping back and saying, have I overcared in this patient? Or have I done too much? Or have I not done enough? And then going to a colleague to say, you know what, that last case was pretty rubbish. Can we debrief about it? The senior, you are leading the debrief, but then there are moments where you need a debrief. So it's acknowledging and realizing that you need to go to somebody else to debrief in a separate way. And that's where psychological safety comes in. And I think that is so essential and important. And especially in a time like AI, again, where someone can say, I don't feel comfortable or competent using AI because I'm not digital or tech savvy. And then I can use that opportunity to try and explain to you why you don't need to be or how I can help set you up
Yeah.
and empower you to, to get on board because it is the 10-year plan and it is the way things are moving forward.
Yeah, I love that answer. I'd said to my dad, like about the last year or two, at a certain point, I said to him, I had a lot going on in life, and I said, well, if you're not, I feel like if you're not humble, then you're just not paying attention.
Absolutely.
And I
And
think that humility is an opportunity. opportunity for growth.
Absolutely. There is a TED talk that's gone viral a couple of years ago. Civility Saves Lives. I don't know if you've seen it, but it's basically about being kind.
I'll check it out. I'm gonna write it down.
Civility saves lives, and it's mainly used in sort of conflict resolution, especially from an A&E, for example, trying to refer to specialities and you've got conflict. The key take home is you kill them with kindness. The more harsh they get, or the more their voice rises, the more you soften and eventually they break. Easier said than done. And there's definitely times where I haven't done it, but it's definitely, and I'm pretty sure there's a podcast on it too. But yeah, Civility Saves Lives is a really empowering TED talk to watch.
I'll check it out. Thanks. What recent successes are you most proud of?
I think the way my digital and AI lead stuff has kind of happened was completely unexpected. If you had told me a year ago that I was going to be digital and AI lead at a trust and I'd have all the support in the world from the trust that I'm working at, I would never have believed you, nor would I have thought I was good enough to do it or had the experience to do it. The fact that I can still be clinical and still be passionate about what I do whilst being passionate about something else and then being able to marry the two. So I love the way my clinical world is unfolding with AI in the loop, with me still being in the loop and me having that final control and me being able to navigate how much or how little I want to use AI.
Natasha, what do you mean by trust? What is that? Is that a business?
Trust is an NHS trust. So instead of a hospital in the UK, we have trusts. So there will be a whole lot of trusts slash hospitals linked together to form a trust.
Okay.
There'll be 3 or 4 NHS trusts that are then linked to a deanery. So most hospitals in the UK, especially A&Es, so there's only government A&Es, there's no private A&Es, there's no private healthcare in terms of the ER. So they're all urgent centers or accident and emergency or ER rooms, as you want to call them. They're all affiliated with an NHS Foundation Trust, and that those are all government institutions and that are linked. So like I said, 3 or 4 or 5 of them are normally linked to a specific deanery, which is then linked to a university. And then that's where you do your training from. So you rotate through the different hospitals.
Got it. What does the future of emergency medicine look like?
It's a really good question, and I'm not sure I have the answer other than
kind of broad. Maybe if I would tailor that, I would say in terms of continuing that element of the human element, patient care, where we've been talking a lot about technology. I think
it's one that's rapidly changing. And like I said earlier, especially in terms of the tools and the tech, it's way ahead of what we're even ready for. But the NHS 10-year plan is to go digital. And the other big NHS 10-year plan is we're going towards prevention rather than treatment. So we're trying to do hospital avoidance and use alternative pathways, and that's mainly 1, to empower patients, but 2, to also prevent overcrowding and exit block are 2 biggest issues at the moment. I think the way A&E is going, I am not at all worried I'm ever going to be without a job. I'm not worried that AI is going to take my job, but I think AI is going to enhance my job. And we hear this quote often regularly, is that AI is not going to replace me, but a person using AI is the one that's going to replace me. I think it's all about using AI right to enhance you. So for me, it's hopefully going to get to a point where the right patients need to come to A&E, so the limb and life-threatening ones, and then we can reroute the ones that don't necessarily need to be there and provide the same standard of care through alternative care pathways that are appropriate and accessible and obviously equitable. As I said, everything in the UK in terms of A&E and ER is all government related, so that no patients don't pay for the care they receive.
I've taken some reassurance with conversations with some of my guests who are leaders with technology and AI, and the common thought I kept hearing was that it's not AI isn't designed specifically to take your job, but really what I'm hearing is the importance of human relationships.
Absolutely.
And I've heard that again and again, and I think I just heard that from you, and so I take some comfort there.
Like I said, it still means a lot to me to be able to hug a patient, to hold a patient, to look them in the eye. And I've said this before on podcasts and in LinkedIn posts. The worst part about COVID was how we had to break bad news and patients or loved ones not having a chance to say goodbye to their loved ones.
Yeah.
It was awful, and I never ever want to practice medicine like that again. I think that's why human in the loop is so important for me. Being so ill with COVID myself and being in isolation and going through that as a patient, and then having an AI tool that was helping us stream patients better, and then more AI tools that have changed the way we practice medicine, has just been absolutely life-changing.
How will technology meaningfully reshape frontline care?
So I think it comes down to governance and funding, and I'm speaking purely from lived experience and from the UK experience. There is a lot of tech out there, but a lot of it has not been tried and tested and piloted in the A&E. If a tool is made for a specialty for 2 p.m., it doesn't necessarily mean it's going to work for A&E at 3 a.m., and that's when A&E is buzzing, and that's when all these crazy things are happening in A&E. And A&E can switch at any, literally with a click of a hand. It can go from super calm to super busy to everything being absolutely full. I think it's about having tools that work for the clinicians. And again, I keep saying the clinicians need to be involved in the tool from the beginning. Don't make the tool and then come to us and ask us what you'd like us to change, because in my opinion, that tool has already failed because you've not had the person who's supposed to be using the tool to give you input. And I think the other aspect to that is involving patients and asking them what they would like from a tool, what they would like from the care. So I think you have the aspect of too many cooks spoil the broth, but this is one where you in fact need all the cooks, because that's going to help you make a model that works effectively and efficiently. And if it's going to add more layers to my already multifaceted brain at 2 o'clock or 3 o'clock in the morning when I'm tired, then I'm not going to want to use it. And because it works, like I said, in surgery, for example, in an elective environment for an appendix that was scheduled and, planned, it doesn't necessarily mean that same tool will be the same efficacy or efficiency in A&E. And I also keep saying just because something is faster and smarter doesn't necessarily mean it's safe. It needs to be safe. So it needs to be continuously audited, reviewed, monitored. And you need to have people that take ownership for those roles. And it can't be somebody that's in a clinical role. And if it is somebody that's in a clinical role, it needs to be somebody that can be unbiased towards it and then give you the good, bad, and ugly about it. And you need to have it tested in the right data set with the right population set. And you need the appropriate medical statistics to get people on board to use it. If you think of really, really intelligent research professors, they're not going to use anything unless you give them the data. And that's what this is all about. And that's why I get really annoyed when patients turn to AI for medical advice, because it's all about the data and the context and the inaccuracies and again, the bias that is associated with that. And just the false reliance and the over reliance that patients sadly are not educated enough about.
Wrapping things up, what lasting impact do you hope your work will have?
I'd like to think that in 10 years' time, if someone was to look back and say, I remember working with Tash and, she introduced this AI tool and she was really approachable, or I made a difference in their life, whether it was personally or professionally, or it was just a small little impact. Because like I've said to you, I think actions speak way louder than words do. And I realize that myself. So if I've helped somebody smile, if I've made a small difference, even if it's for 1 minute in their life, and they can remember me 10 years down the line, for me, my job has been done. I don't need to have 20 papers published and I need to be on, many international forums and I've spoken at hundreds of international webinars. I would love to do that. But if somebody remembers me and if I've made a difference for them in whichever small way it is, that's all that matters to me. That's why I did medicine in the first place. And like I said, if I can pay that forward, then I've made a difference.
Impacting individuals. Yeah, that's fantastic. Dr. Dole, thank you so much for spending some time with us on the HealthCast. It was a real pleasure to hear about your work and the impact you're making. Thank you so much.
So I really, really appreciate this. Looking forward to chatting more.
Thank you. Stay tuned for another episode of the HealthCast. Thanks for listening to the HealthCast. If you enjoyed this episode, please like, follow, and subscribe. And share it with someone in healthcare or digital health. And if you're a healthcare leader focused on scaling your business or improving operations, I'm always open to connecting. You can find me on LinkedIn. There's a link in the show notes. Thanks so much.